Welcome to the Cup of Nurses podcast.
Hey guys, welcome to Cup of Nurses podcast. We're your hosts, Matt and Peter.
What's up, guys?
Today we're going to dab a little bit into some current news. We're going to talk about the medical device industry, and then we're going to touch upon patient-centered care and how you should approach patients.
Because it's not only the patients, it has to be the holistic approach.
Exactly.
Which is being mindful of everything that's going on, like patient stress, their medications, polypharmacy, the interactions between a doctor, the education. What else am I missing in there?
Well, empathy, comfort, and coordination. But we'll start with some healthcare news. So, medical device industry, in 2018, their revenue was $180 billion. The United States is the biggest economy in this medical device industry. So we produce the most medical devices, and we also use the most medical devices.
And a lot of people don't know that these devices aren't tested on humans at all before they've even come to the market.
The crazy thing is, one of the processes to get your device approved, you got to go through a 510K process, which basically, if you can prove that your device is just as good as the leading device in your sector, your device will get approved without any kind of human testing. So if you can prove on animals that your device does what the current device does, then you can get it approved without any humans. You can just send it out to the market.
And the people that are getting trialed are the humans. So animals can't really tell us much about how we're going to react to these devices. Like we watched a documentary and like the device called Esher that basically closes up, creates inflammation in fallopian tubes and is a contraceptives. A lot of females didn't know that it's going to be a cascade of different effects, like stomach pain, abdominal pain. One of them had a hysterectomy because of it and couldn't have kids anymore.
Yeah, and so this Esher company hypothesized that their product is just as good as the contraceptives out there, but they have a different method of doing it. And it's crazy because this was never tested on humans. So I'm not even sure if it was tested on animals, but they were able to prove that it was just as effective as like oral contraceptives or any kind of other getting tubes tied, anything like that. And they basically implant like a little wire that like matches the cause of inflammation in one of the ovaries, and it just gets necrotic. But it did work, but it was associated with a lot of different symptoms. So the inflammation was all in the abdomen. It inflamed the cervix, inflamed the uterus, inflamed all those female reproductive organs.
Not only that, but after the patients asked them, how can we remove this device, they never had an answer. So these devices that are implanted in females, they never gave the women the ability to take it out, which caused a lot of issues. And if we look at the stats, like in the past decade, medical devices were a result of 80,000 and over 1.5 million injuries in the past decade, leading to $8 billion in lawsuits.
Yeah, so 80,000 deaths and 1.5 million people injured.
With the loophole of not having human trials before being tested.
Yeah, that's crazy.
That's an industry that's not even made aware of to like the public. We always think about like, polypharmacy, pharmaceutical companies, but these guys are the real hitters here. Yeah,
you never hear about the medical device industry on the news or the new actual products out there, or what products are actually out there. You just hear about them getting done in the hospital. You don't really hear advertisements on them either. I've never seen an advertisement for a medical device.
Even like if you look at commercials, I feel like a lot of TV commercials have just advertisement of medicine, like the pills, or have, Eliquis and a blood thinner. They never talk about devices, which is interesting.
No, yeah, you don't see it at all.
Do you think that's illegal, or there's something going on that you can't advertise on TV?
No, they probably just don't need to. They probably make so much money through the insurance and through kickbacks and just in hospitals that they don't need to advertise like that. They provide it straight to the practitioners.
And the practitioners are the ones that are promoting this, just like a Tesla almost. Yeah. Like Tesla doesn't have any marketing. They just sell like a well-rounded product.
Yeah, they have marketing and stuff. But so like the marketing that they do, these device industries, they market it to physicians. They don't market it to general public. because you don't buy that. We buy that product, but we get that product inserted into us, so we don't decide what product goes in our body.
So it's
The
like
physician
it's like a pacemaker. Like you can't shop around for what kind of pacemaker you want to choose. The doctor that is recommending you the device will recommend the brand.
Yep.
In a way.
Yep, and he puts that in his whole life because that's what's paying him money.
And I wonder how many like different pacemaker brands there are.
I have no idea.
That'd be a good reference.
It's a good thing to look
show.
up.
Yeah.
That'd be cool. But that ties into fairly nicely to our nursing discussion for today. So we're going to talk about patient-centered care. And there's 4 things that we see are most important to patient-centered care. And that's respect, coordination, information, and empathy.
And we're not realizing that all of these aspects in patient-centered care, it's directly impacting like outcome and satisfaction. And as we know that these satisfaction scores, which we always get tested on, always have meetings about, they directly impact the money that the hospital gets reimbursed, which kind of pays and funds us.
Right.
So patient-centered care equals great satisfaction, great outcomes, which equals money in the hospital's pockets, and we get employed and keep our job.
Yeah, there is a different kinds of like care services or different ways of providing care, but the patient-centered care approach has been proven to be the most effective out of all of them. Because it's more of a patient-centered approach, so you kind of put the patient first.
Is this like a model that we're following? Is
Yeah.
this known by who's the one that like?
I have no idea who created this model.
Okay.
But just one of the models, and that's the one I found that correlates most with the best benefits.
Okay, so it's some Florence Nightingale stuff.
I mean, it's probably opening up more than a window.
Yeah, so I wouldn't think respect would be number one. So that's an interesting way to start the topic of patient-centered care. So what does respect entitle?
Respect could dive down deep, or it could be something simple, like dietary preferences. Like some people don't eat pork or beef for religious reasons, or because they choose not to, or vegetarians. One of the best ways to make them feel more relaxed and less stressed is you actually give them food that they'll actually physically eat. You know, if they don't like that kind of food, or they're allergic, or they don't like bananas, don't give them any bananas. At least they could enjoy the meal a little bit more. Because hospital food isn't good. It sucks. So if you get them at least of something what they want, they'll feel a little bit more in control as well.
I've had it in 8th grade, and I can't remember the way I ate or joined the meal, but I do know that sometimes patients do say that the food isn't the best, or like, oh, this is too dry. So unfortunately, always people have a bias the way they like to do things, but the hospital should be very conscious of the way they create their menus to have like a full spectrum, everything that a person should eat, like no pork, or it has to be kosher. I think probably being vegan right now. I wonder if our hospital actually attains to any vegan meals.
I don't think I've ever had a vegan patient. Personally.
Because they're probably healthy and they're away from the hospital.
Yeah, maybe. But vegan is kind of new, so we'll see. We'll see how things are more down the line. Because remember, we take care of people that are older. So they have different values and different customs than what we have now. So the diet Dad ate is completely different with the diet that we're currently eating.
So maybe in 20, 30 years, we're going to start seeing vegans being in the hospital.
I'm sure, yeah.
And that might be an issue. And I wonder what kind of healthcare problems they're going to have.
Right.
And then we're going to start connecting the dots and say, hey, being on a vegan diet is, causing A, B, and C.
Yeah. And then, the keto diet causes this and this. And you compare and you combine those 2 diets, and then you find like the best one.
So we intermittent
structure.
fast. Do you think we're going to end up in the hospital?
At some point, probably.
But what do you think people that intermittent fast would come into the hospital for?
I don't know. Probably when they're older, the same thing we see nowadays. So probably cardiac disease, whatever, is kind of more built in your genetics. Because we're kind of shaping, now that we're become more modern and more in touch with ourselves and what we do, we eat healthier. We exercise, and it's going to prolong our life. But we also have our genetics, which is going to have some kind of effect on your health. And add genetics and an old age, and you probably you have a slew of problems. So I'm guessing it's probably some of a cardiac disease.
Can be cardiac, and maybe it could be a peaceful death for all that we know because we've been eating better. But we also have to realize that specific
or cancer even too.
Cancer specific foods are turning on and off these good and bad genes. So for the longest time we've been realizing the genetics are the issue. We also have to come into factor that food is turning on and off specific genes that are contributing more to a specific type of cancer.
Yeah. I said better myself.
So what else is there under respect? Let's see.
Respect, even if you think about it, I had a Buddhist patient a few months ago, and he wanted to hum and go through his prayer ritual, and he wanted me to leave him alone, so I just left him alone, and give him that 15 minutes or 10 minutes to himself.
And I've heard somebody, even somebody say they want to pray with me.
Yeah.
But the craziest of them all would be like end of life stuff. Sometimes people have interesting needs and wants. One of them was a patient where the father wanted to take the patient home after he expired, he died. And I think that's completely illegal. Like, you cannot just send a body home to a patient's family so they could do their rituals on. I don't know how the funeral homes work, but the hospital will not release the body to a home.
Yeah, no way. That's really interesting, though. Like, I've never had anybody ask me if they could take the body home. That's something you would have to respectfully decline, even though you're supposed to kind of do what they want. You cannot physically do that. So
I froze up.
Really?
I'm like, let me ask my charge nurse because I have no idea.
Yeah, respectfully decline and just move on, I guess, unfortunately.
And that was probably the interesting end of life question that I...
Didn't you have a family, like, sing at one time?
Oh, that happens all the time.
Really?
There's like 16 people deep in there, and they're doing a
cool.
little like prayer and to whoever their higher being is. And it's interesting. Some people ask for like a special oil that the priest will provide. I think the Polish culture is really big on
like
that. And
anointing, or whatever it's called.
anointments, yeah. So they provide that. Probably simple things, and there's also hospice services that will provide a great deal of end of life care if you get accustomed to it.
Right. And there's priests there and like pastors and whoever, different religions. You know, they could call somebody and somebody will come in, or somebody from like your regular church could come too. You know.
I've had that. I've had like a rabbi that came in, and he was with the patient for like 2-3 days, and he would sit down with the family and give them all these lessons of hardship and how to get over things. So that the hospital could provide you with like end of life issues or end of life services, but more than likely you'll get like different end of life services from like your religion facilities, and that's where you kind of see the taste and culture of things and what different people do.
Yeah. So another one of the things with patient-centered care is coordination. You want to coordinate consults. You want to let the patient know that, hey, endocrine's going to see you tomorrow. The physician's going to round in the morning. Let's say if his blood pressure, or not blood pressure, but let's say blood sugar is an issue for this patient, you want to let the attending know, be like, hey, can you throw in an endocrine consult? Because this all just betters the patient. Everyone kind of knows what's going on. Now the cardiologist knows that he's been having hyperglycemia, and now the attending knows he's been having hyperglycemia, and everybody knows he's been having hyperglycemia.
And no one does anything about it.
But that's why you want to recommend, hey, can we put endocrine on? It's been 2 days. This guy's like chilling in 200s.
And that's where, like, you know how we talked about nursing burnout? If you're not burnt out, you're aware of these things, and you help coordinate the care, because a lot of people don't realize that nurses are literally like, they're molding the whole entire care, the transition of care. Like, just like you said, like if there's physical abuse on that patient, we're the ones that call, follow up with that. If there's someone homeless, we should put in a consult for social services, and the social services will deal with that or try to find housing for the patient. Just like you said about consults, it's never bad to ask like your primary physician, hey, I think this is going on, or the patient is on this much narcos. Maybe let's put a pain specialist in. I don't think I ever asked for one, but I'll do it for like a cardiologist. Like, hey, this guy's having PVCs, or he has a pacemaker. Maybe he should get checked out. It's not pacing, and the physician will do that.
Yeah, the consults are there. Use them when you need them. It's not a big deal to consult somebody. You also want to coordinate with your patient as well. So what I like doing when I come in is I like setting up some time frames and some schedules. Be like, hey, my name is Peter. I'll be a nurse for tonight. Tell him hello, how his day's been going, and tell him you're going to be back like in an hour. Tell him you're going to be back at 9 and 10 to do your assessment and give him his meds. And then you're going to come back at 11 and shoot numbers, and then you'll try and leave him alone for most of the night. And you're going to come back out again at 4 in the morning to draw some blood. So they kind of have things to look forward to.
And I feel like a baseline of the shift.
They kind of know how your next 12 hours are going to go. That provides, I feel like a lot of comfort. And I think it also decreases the amount of time they're on the call late. Because if it's 9 o'clock and they're kind of, comfortable, but they know you're going to be coming in at 10, they might just wait in that hour and might just address the issue when you're already there. That way you don't press the call late.
That I completely agree with that one. Just like when you tell them about things that are going to happen or who are on consults, some people come into the hospital completely delusional. They're like, I don't know what's going to happen, or I don't know who that was. Sometimes I like to encourage patients to have like a little notebook, write down all the questions you have, or okay, you're in the ICU because you have high sugar, you're going to have an intensivist, you're going to have a primary that's going to see you, and then you're going to have like endocrine that's going to see you. If you have questions for any specific doctor, like Where can I get my Where can I get my medications? Should I adjust my blood pressure med? Write those questions down. Then 9 o'clock comes or the doctors are rounding, they could address all those questions because they forget.
Yeah, that goes very well into our next point, the fourth one, which is education and information. People want to be informed. Like you said, a lot of times these people are there for the first time. Maybe they had like a traumatic car accident, just a stroke, a heart attack, or something. And that's their first time ever in a hospital. And now they just got extubated. They're incoherent. They don't know what's going on, and they're in a completely different place than they were when they first passed out. That's very scary. Even when on their vent, you still want to talk to them a little bit. Maybe they're brain dead, maybe not. You can't always tell for sure. So you just want to keep a little bit informed. Just say hello, just make your presence known, and just talk to them sometimes.
You always should say things, even like to the patients that are in the ICU, sedated or intubated on life support. It doesn't hurt to explain things to them because I'm sure maybe they still have a sense of hearing, and mentally they're gonna have some kind of like hope or less anxiety, less fear, to help them transition to everything that's going on.
Yeah, like especially with sedated patient and intubated. So if you're gonna go in there and turn them, do their dressing, don't just walk in there, put the lights on, turn them, do a dressing. You want to walk in, just make sure they know that you're there. So acknowledge them, be like, hey, we're gonna turn you on your right side now. We're gonna change the dressing now. It's gonna hurt a little bit. We gotta wash it out. It's gonna be a few minutes, and then do it.
I feel like we also, as like healthcare as a whole, we do a bad job educating the patient. So let's just say the patient has hypertension. They come in and they leave with a blood pressure pill. They come to the doctors with a blood pressure pill. They have no idea about the side effects of the pill or why they have hypertension.
Yeah, they might know they just get lightheaded.
Yeah, or the risk factors for why they have hypertension or how to stop hypertension, how to like change lifestyle ways to stop that. They don't get any of that education. They're just like, yeah, I'm on this pill. And they continue doing what they do. And that bothers the heck out of me because we're not teaching the American public how to properly live healthy.
Right.
We just push a pill. The doctor's busy, stressed out with a bunch of people. The nurses are stressed out and busy. And that's freaking healthcare in a way.
Especially with during emergency situations. Like say you got to throw somebody on a BiPAP. He's been gasping for air. He's been fine all day. He's been gasping for air. Now you're throwing a big mask on him. Like imagine how that feels. And he doesn't know what's going on. Everyone's rushing.
What's a BiPAP for those that don't know?
A BiPAP is a machine that it's a mask, and it's a machine that pushes air in your mouth.
Positive pressure to open up the alveoli.
So it makes you breathe better. It makes your oxygen saturation go up. It expands your lungs. A lot of times people get acidotic or they go respiratory rest. That's probably the first step, and then you go into intubation. That doesn't work.
And the story, so you throwing a patient on BiPAP.
Yeah, and they don't know what's going on. So you want to kind of explain what you're doing and inform as you go, because that's gonna be, imagine you getting just a mask put over your head. That's scary, man. Like you've just been gasping for air. You feel like you're dying. Like your chest is caving in. Now we're putting a mask on you. And even when you're intubating somebody, you want to tell them, hey, we're going to intubate. Just pop them before you put the sedation and the paralytic if you need it.
And that's another thing when it comes to like, maybe not. Let's transition to the next one. So on top of information, in order to have total patient centered care, you have to have comfort and empathy. And when it comes to comfort, it could be little things like fear or anxiety, and that's not only the patient, it's the family. It has to be holistic. So maybe the family's freaking out that the patient's about to have the surgery, and you have to calm the patient or the family, tell them that everything's going to be okay. This is the way that things are going to be. And let's just say they have a procedure. Ask them, do you have all your questions answered? If they don't, make sure you get the doctor on the phone, or before they go down, someone takes care of everything. So they go into that procedure with some hope.
Yeah.
They should.
You should always be giving hope and putting people through hopeful situations. You always want to say that, this procedure is going to go well.
There's a gray area there.
There's a super gray area.
You can't give false hope.
The last thing you want to say to somebody, hey, is like, hey, I don't know if you're going to make it. The physicians could say that the physician tell the patient what are the risk factors, what are the chances of them coming out, what would make it be successful, how would it be unsuccessful. And obviously if the patient agrees to that procedure or treatment, you don't want to say, help you make it. They were decided on doing this. And by you saying, hey, help you make it, it could show that you expect a negative outcome. You can just be like, hey, everything's going to go great. You read over all the information. You feel good about this. We feel good about this. We have great physicians. It'll be okay.
But sometimes there's like this gray area where you personally know that patient is not in good shape, and the family asks you, do you see a lot of these patients? And what usually happens?
Yeah.
And sometimes you want to bite your lip, and you don't want to lie to these people, but you don't want to tell them positive things, because I hate giving false hope. You're not supposed to tell people, you know what, John is doing a great job. He'll make it. He's a fighter. Those are very positive, influential things you want to tell people. And I want to tell those people that. But at the same time, I say, hey, John is really, really sick, and we're just going to have to play it by hour and play it by day and see where he goes. His oxygen is improving, but within an hour, things could change, and he could be going up on his PEEP and his O2 when they're on life support. And I kind of give them this 50-50%. When I'm in there, I'm always positive, try to make them laugh and doing all these good things. But I always let them know that the outcome, he's in bad shape, because that's just the patient population I deal with at work.
Yeah. That's a very good approach. I think everyone should take that kind of approach to making it 50-50. Don't make it very positive if you know it's not that positive, and don't make it super negative just because you don't like the guy. Or to make it 50-50.
Right.
Be reasonable with these people.
Yeah, and if it's like it's a heart attack and he had a stroke and he got stented, post MI, and he's doing okay, there's room to give positive hope, or he's gonna make it. He's fine. You know what, Kelly, why don't you just go home and rest? Your father's fine here. Your husband,
Yeah, not like reinforce like, hey, I'll be here all night. So if anything changes, I'll call. If you guys ever get worried, have a bad dream, feel free to call me anytime.
And that's that trusting also. So there's those family members that are exhausted from what's going on with the family. He might have came in 3 times in the last month. And you as a nurse, when you show that confidence, that patient, that family's going to give trust, and you're going to go home. Or they're going to go home, sorry. So it's really important to create comfort for the patient and be empathetic.
Yeah, most definitely. Yeah, you reinforce the patient and the family as well. But you also want to address pain. I feel like pain sometimes we overlook. Like we hear on the news that, hey, people are overdosing on pain medication. We're giving out too much pain medication. But some people are generally in pain and ask for that pain medication because they need it. Like with the intubated patients, their blood pressure tends to go up with pain. You might want to give, a Norco or some morphine before you give the hydralazine. It might be a lot more effective. It might even stabilize throughout the whole night instead of pushing hydralazine every 4 hours or every 2 hours or whenever you need to.
And that's crazy to me that where we work currently in Oakland, they don't give the intubated patients like a propofol fentanyl mix, which is crazy because usually propofol is a sedative and it sedates the patient, but you also have to give an analgesic for pain. And usually fentanyl is a good combo for that. And these patients on vents are on propofol and they're hypertensive, and I was giving hydralazine to lower their BP, but what if it's a pain? Psychological or a physiological response to pain is blood pressure, and we're not properly treating that.
Yeah, I'm really curious on how, or the percentage of successful intubations this hospital in Oakland has compared to the hospitals that we work in. Because we see a lot of these patients here currently that are in no sedation and no analgesia, and they're just chilling on the AT tube. Yeah, it's very interesting. I'm not sure what the stats are.
Do you think when it comes to outcomes like physically or emotionally, they could be scarred from what they experienced because they weren't probably sedated?
Well, right now I'm thinking about physically, like how successful is each intubation? When you're completely off any sedation or any kind of like drips like that under when you're intubated, compared to being on all that stuff in Chicago and then getting like weaned off it a few hours before you get extubated. I wonder whose stats are better. But it's pretty cool when they bring out the emotional stability and like the emotional aspect of it, because I don't really think about like the mental stuff that would go through when you're fully aware of what's going on and you have a tube down your throat. That's like probably some intense feelings. I don't know how much of like emotional mental scarring that could happen, that could cause in somebody.
You probably can, because some of these people that, let's just say, we can't take the tube out because their lung sounds are bad, but they could communicate with us and they're alert and oriented, and you tell them to squeeze and they squeeze their hands, and we have this like communication board, and they could circle like if they're angry, if they're sad, if they're happy, if they need to be repositioned, if they're uncomfortable, if they're in pain. And sometimes you're communicating with these people and they try to scribble something while they're on life support, and sometimes it's frustrating for them because they verbally try to lip something to you, and you're just like, I'm sorry, I don't understand. That must be so frustrating for them.
That's very intense.
And they must be emotionally scarred.
Right. Compared to somebody that's completely out until like the few minutes until extubation.
And sometimes like they scribble so bad, I'm just like, I don't understand what you're writing. I'm so sorry. And sometimes I leave the room and we never establish any kind of communication, and I'm just like, dang it, I wish I understood her, and you can't. And it's frustrating.
I wish you could help, but you can't because you don't know how. You don't know what they want. Yeah, I'm really curious on those stats though. I'm really curious how this hospital's stats extubation stats compared to ours.
What else do you think like patient-centered care is important? Because we talk about the patient a lot, but the family is a whole nother thing. Because I feel like sometimes the family could be more overbearing on you than the patient himself.
Yeah, my perspective on that is you always try to focus on a patient and then the family's background. So if the patient, doesn't want pain medication and the family's pushing pain medication, you can just go with what the patient says. They're grown adults, unless you're working with peds. I'm not 100% sure how that would work, or any kind of infant. But if the patient says he's not in pain and the family's like, no, give him pain medication, he's been taking it, for 6 months now, every 4 hours, he needs it every 4 hours. The patient's like, no, I'm fine, I'm okay. Sometimes family tend to push tasks on you, I think that they want or they think are important on you for you to do compared to what is important and what you want to do for the patient and what you have to do for the patient.
Yeah, and another thing is let's just say you have like 10 family members. They don't coordinate properly too, and you tell one family member what's going on and what's going to happen in the next like few hours, and then another family member asks the same question. So we would really appreciate as nurses if you have a big family, there has to be one designated person that, or maybe two, that receive the information and then they could relay it back to the family.
Yeah, or if they have a password and somebody does not know that they're in the hospital and you can't reveal any information about that patient, that's very overbearing. Or everyone, it's pretty crazy, man. Like, what if, like, somebody, like, let's say your sister didn't want you to know her medical.
And that happens all the time, and it blows my mind.
And she gives you a password, and you're trying to call, what the hell's going on? I can't get any information, and she's like, sorry, you don't have a password, I can't give you any information.
I had a patient in the ICU, intubated, and the power of attorney that overlooked the care was the brother, and he and the sister were in a fight. So there was a restraining order regarding the brother and the sister, and she couldn't come visit her own mother because their brother had a restraining order, and he said she can't see him.
No way.
And if, let's just say, the daughter were to come, we couldn't do anything. We had to call police, and they had to figure it out regarding the restraining order and
really?
Stuff. Like, that just messed up the end of life. Like, there's these kind of situations.
That is pretty crazy. Wow, that'd be so hard. Imagine him always being there just so she can't see him, or she can't see your mom.
It's messed up, and it's passed along, and we as nurses are unfortunately, helpless in the situation. We can't do anything because this is something that's been going on for a while, and we're just treating the patient, and the family part is just something that's out of our hands.
It's interesting to see all the family dynamics going on. A lot of times it's kind of sketchy, kind of sad.
And you can tell where it's dysfunctional.
Yeah.
It's sad.
It's sad. It's like, dude, like, this guy's in the hospital. Like, can you just agree on something? Let's all be adults here.
Yeah. Speaking of messed up stories, there was one time there was a family that couldn't decide on what to do, and they had a Disney vacation planned. So while the mother was intubated on life support, that family was in freaking Florida Disney, doing their vacation, deciding what to do with the mother. And that patient is laying there for like 4 or 5 nights.
Wow.
Like, come on. And that's dysfunctionality at its greatest. It's like, what the heck? You got this patient that, remember, healthcare could do a lot of life-saving things, which is keeping this lady alive.
You could keep alive forever if you wanted to.
Exactly. And the family can't make a decision, and it's not being pushed properly, and you're letting this patient suffer. She's suffering. What is her quality of life right now? And some of these patients that that will just never make it are still being kept down because of family issues, family conflict, and just past things that get brought up. And not only is death an emotional thing, all that conflict together is just a freaking spaghetti of crap, man.
Yeah, and you can't get involved. you can't get involved. And if you get too involved, you got to take it back home. But you can't do anything.
The only thing we could do is just be an advocate to our patient.
Exactly.
That's all we could do.
Just reinforce, the importance of the patient. That was a pretty good episode. You want to touch on anything else?
I think we're pretty good. We're 30 minutes in, guys. If you guys ever have any comments, concerns about what we do, what you would like to hear from us, give us like a drop down, give us a comment, email, and we'll try to get your questions filled in.
Yeah. So we touched upon some patient-centered care that revolves around comfort, empathy, respect, information. And we also touched up a little bit on the healthcare industry of the medical device companies.
Yeah. So the people that are the viewers that are nurses, guys, take this into consideration. Maybe you could improve your nursing. And the people that are non-nurses, just think about the way healthcare works, the responsibility of a nurse, and the next time in the hospital, just know the questions to ask or what to expect in order to make your hospital stay a little bit better, even though it sucks.
Yep.
And we don't like you see you there, but if you're here and if you're there, just make the best of it. Respect the nurses.
We're everywhere.
And we're everywhere. We're watching. We're like the little elves on the house
crackers?
during the Santas.
Oh, for sure.
Santa's coming, the elves. It's something.
For sure.
All right, guys. See you guys next week.
Keep it tuned with Oakland.